Hello, this is Optimum Health Solutions. I'm your host, OJ Odia. Today we have with us Professor Rosemary Ogu, who is a consultant obstetrician gynecologist. And she's with us today to throw some light on recurrent miscarriages. So we will ask her, and I'm sure she's will be able to enlighten us at the end of the day on why some women do have recurrent miscarriages. Professor Ogu, you are welcome.
Thank you very much, Prof.
Thank you for honoring our invitation.
It's my pleasure.
Now, what is miscarriage? Is it the same thing as abortion?
So generally, we'll say that miscarriage is the termination of a pregnancy before the age of fetal viability. That means that baby will not survive. Okay? Worldwide, you would say 24 weeks, 28 weeks, in some instances, 20 weeks. But in Nigeria, we still take up to 28 weeks. And so if a woman loses a pregnancy before that pregnancy is up to 28 weeks, we say that woman has had a miscarriage. How is it different from an abortion? Generally speaking, when you say miscarriage, it's an inadvertent thing. It's something unexpected, something you didn't wish to happen. And so we would use a miscarriage for a spontaneous loss of pregnancy, whereas we would use an abortion for a pregnancy that the woman consciously removed, so to speak.
Okay.
So when it is not spontaneous, when it is something that you went to do by yourself, you call it an abortion.
That is intentional.
Yes, intentional.
Okay.
But when it happens on its own spontaneously, you call it a miscarriage.
Yes.
It's how people view things.
Yes.
But generally, when you say an abortion and a miscarriage, they're supposed to mean the same thing. The termination of a pregnancy before the age of fetal viability.
Okay. Now, why is it that some women have recurrent miscarriages?
Okay, so what we describe as recurrent miscarriage is somebody who has had 2 or 3 miscarriages, in sequence. And so once it happens, initially we used to say 3 repeated pregnancy losses makes you make a diagnosis of a recurrent miscarriage. But because we now know that after 1, you have a second one, you may likely have a third one, we now say after 2 that it's a recurrent miscarriage. And so you may find women.
That means we don't wait for 3.
Yes, you don't wait for 3 anymore, because it's like, why are you waiting for something that you know will happen when you can do something? And so you have women have recurrent miscarriages. Generally, we would say chromosomal abnormalities. If there's something wrong with that pregnancy at the chromosome level, at the level of the building blocks of that baby, the woman would just spontaneously have a miscarriage.
That baby will not survive.
That baby won't survive. So the body clears it out. So 50% of miscarriages will be due to spontaneous chromosomal abnormalities.
So will it keep recurring?
Yes, it will keep recurring. But, and I'm saying the very big but, because these ones that happen like this, there may not be anything you can do about it. If there's something wrong with the chromosome, it's not even a good pregnancy, so you don't want it. But there are scenarios where you have recurrent miscarriages from things that you can change. For instance, when we talk about an incompetent cervix or an insufficient cervix, the cervix is that part of the womb that's supposed to hold the baby in the womb until the baby grows to maturity and can be delivered.
The neck of the womb.
Yes, so that neck of the womb, where you have that neck of the womb not having enough, is insufficient. It can't do its work. And so you can't hold the baby within the womb. So you have an insufficient cervix, what we used to call cervical incompetence. Okay. So when you have that, the woman just keeps having recurrent miscarriages.
So anytime it reaches a particular month,
the baby just goes out. The baby just falls out. And these are things
without any labor,
without any pain, nothing. The woman just stays, and the next thing she just sees a bag of water, and baby just falls out. And so With insufficient cervix, it's something that you can treat. It's something that you can take care of. Unfortunately, we still have women who are not aware that there's something like that. And so they tell you, oh, somebody is doing it in the village. Somebody is doing it. Oh, when I'm pregnant, don't let anyone know, because once they know, it will come
They
out.
will come out, yeah.
You understand? And so some of them even get pregnant and hide. And they don't come to the hospital. And then by the time they are coming, you see the membranes bulging. Everything is out there.
So something can be done about it.
Yes.
Okay, so let's talk about other causes then.
So other causes, you have infection. Other causes, you have chronic diseases. For instance, somebody with chronic hypertension, somebody with uncontrolled diabetes mellitus.
Yes.
When you have all those things, you can have recurrent miscarriages as a result.
So it occurs the first time, it can occur the second time, and so
People
on.
with heart diseases, some heart diseases that are not compatible with pregnancy. So the body just removes it.
They can't carry kidney diseases and so on.
Yes.
Okay.
So chronic diseases, infections, like the touches, there's something they call touches complex, different kinds of infections that a woman could have, and they're all treatable anyway. So they're treatable.
But there are some rarer ones, like the baby and the mother are incompatible.
Oh yes, the ABO incompatibility. Prof. ABO incompatibility, as simple as it is, a woman gets pregnant, has a different blood group from her husband, they don't check, they don't know, they get pregnant, and the incompatibility can lead to a miscarriage in the woman. Okay?
So like resource negative and resource positive.
Yes, all of those things.
And those women usually will have a normal pregnancy at the beginning, then the second pregnancy usually goes wrong.
Yes.
And then of course subsequent pregnancies. And she may even die in the process if she's not careful.
So you have, because of the incompatibility, by the time the woman is sensitized, there's something we call sensitization, where a different blood,
of the baby fights that of the mother.
Into the mother, and so fights the mother, and then now gets ready for the next pregnancy. And so it's in the next pregnancy, as the woman becomes pregnant, those antibodies now fight that baby, and some of them can kill the baby in utero.
It's a relatively rare condition.
It's rare, but it can happen.
It does happen.
But when we say it's rare, we right now we don't wait anymore. So what we do, as soon as you come to register for antenatal, we check your blood group, group. And so if we suspect an ABO incompatibility with you, we treat. Okay?
We'll handle it immediately.
Yes, we'll handle it immediately.
Okay.
And then for everyone having their first pregnancies, as soon as they deliver, if it is someone who would have a rhesus negative, for instance, they get the anti-immunoglobulin immediately.
Yes.
So we don't even wait for them to get pregnant.
The one they call Rogam.
Yes, we give them Rogam.
Okay.
As soon as they deliver, within 48 hours.
And you give it repeatedly?
Yes, we give them so that they prevent that sensitization, so that the next pregnancy is okay. Is okay.
So when they don't
what women should know, the beauty of registering for antenatal and registering as soon as you discover that you're pregnant, within 8 weeks of a missed period, the women should register for antenatal. And as you register for antenatal, these checks are done. And so the checks for preventing a recurrent miscarriage is part of the routine things that are done as you come to register for antenatal. Okay.
So for cervical insufficiency, there is a surgical procedure?
Yes, there's a surgical procedure that is done, what we call a cervical cerclage, okay, where you put reinforcement on the cervix to make it sufficient, okay. So generally would use a mescaline tape. It's a special tape. The needle is a special needle, and it just goes round the cervix, and then you reinforce the cervix. And when the woman is ready to deliver, when the time has reached at 37 completed weeks, you now take out the tip. and the cervix opens and the baby can come.
Okay, so the woman has to be in hospital
The woman
throughout
has to be
until
in
delivery.
hospital for the methylene tape to be passed. It depends. It depends on the individual. There's something we didn't say before. When we're talking about recurrent miscarriages, the risks are more if you've had a miscarriage before. The
Okay.
risks are more if your age is older. You're older. If you're younger than 25, your risk is less. If you're older than 25 to 40, your risk is more. The same way, when you want to have a circlage done, you would generally be admitted into hospital. Circlage is inserted. You can go home after 1 week. But in some scenario, you need to stay back for the entire duration of the pregnancy,
To make
depending
sure
on
that
the
that baby
individual.
survives.
Yes.
Okay.
So you may need to stay for long.
So
And then the removal happens at 10.
just before delivery.
Yes. So the circlage is removed.
That is good. Now there's a solution to that.
Yes,
What about this multiple infections and so on?
Yeah, so there's solution too for infections you treat. Okay. And that is the beauty of what we call preconception care. It's not widely practiced in Nigeria, but it's something that we should all get into. Before you decide to have a baby, once you've made up your mind, you should come to the hospital. We have preconception clinic in our teaching hospital. You come to the hospital, discuss with your doctor, have all these tests done so that if you have any of these infections we're talking about, you are treated. And so you're ready and you go on and you have your baby. And
Baby, so everything is
yes,
cleared just before. So you don't wait to be pregnant
no.
and then
Then you
once
now
I have a
come,
problem
you
or after
already
the
have a
first
problem,
miscarriage,
or
you
after the
now start
miscarriage,
looking for solutions.
Right.
Okay, so you're encouraging women to come early for antenatal care.
Yes,
Even
come for
before antenatal
preconception
care,
care. Yes,
they can
before you get
also
pregnant,
get
you should come.
some form of treatment. Now, the for women who are newly married, what advice are you going to give them so that they don't fall into this problem of recurrent miscarriages?
Yeah, so for newly married women, the advice would be to come to the hospital, before pregnancy. Okay? Come to the hospital. A one-off thing. You come to the clinic, you're tested, your blood samples are taken, and tests are done. I know some churches where you go for marriage counseling and they do these tests for you. At least they do their genotype for them, they do their full blood count, they check them for diabetes, they take their blood pressure. Some churches do that as part of packages for marriage. Yes. But the onus is on the individual. If you're trying to start a family, please come to the hospital. Let's have some consultation. Check your blood pressure, check your blood levels, screen you for infections so that you can have a beautiful, healthy baby, healthy mother, healthy baby.
So, everything ends on a positive note.
Absolutely.
The baby is fine and the mother is fine.
Absolutely.
And that is the aim of this program, to ensure that we prevent complications, that is, nip them in the bud before they come out, before they rear their so-called ugly heads.
Fantastic.
Thank you very much.
Listen.
Please go ahead.
Listen. If you're planning a pregnancy, please come. Let's discuss. Have preconception care. If you have lost a pregnancy before, please come. It may just be recurrent miscarriage starting. You don't need to suffer from recurrent
because there are other tertiary hospitals, even secondary hospitals, and they can also take care of it.
They can do something. Yes, they can start.
Because
please
most
try.
women live in the remote
rural areas.
What they have is primary health care.
It's fine. Go to your primary health care center. They can take care. They can do something. Yes, they can.
They have midwives, they have doctors, and they can do that.
Something.
Okay.
All right.
So, viewers, please, if you fall into any of these categories of women that will require care, don't wait for miscarriages to start occurring. Go have a check in any hospital, general hospital, primary care center, teaching hospital, and you will be taken adequate care of. I don't think one should be afraid of going to hospital, because people are usually afraid. When I go to hospital, who do I know there? Who's going to see me and so on? It's not as difficult as that. Hospitals are generally much better, have better approach to patients these days, I think. So, thank you for viewing this program. Thank you very much, Professor Ogu, for coming. I'm so happy that you finally made it.
We've been trying
After
to do
all this
this.
for a long time. And I'm
Thank
happy
you.
that you are able to come today.
Thank you. Apologies.
So we
And thanks for
appreciate.
having me.
Thank you. And
All right. Take care.
for viewers, please subscribe, share, and like. Thank you. Bye for now.